First of all, I would like to extend a special thank you to our 2022 Lunch and Learn series sponsor, which is Bubbly Hall. They will provide delicious lunches for each Lunch and Learn event that we have here in person at Healthy New Albany throughout the year. And their support helps us to offset the cost of these programs. Just a little bit about Bubbly Hall. They are the first food and retail hall in New Albany. The establishment is part of a new overall lifestyle concept created by the Granaz Group that aims to develop community-driven, happy and enriching experiences. It will offer curated artisan stalls and shops, fast casual cuisine and distinctive retail, as well as event space. I have personally met the leadership team that's bringing Bubbly Hall to New Albany, and I'll say they are a tremendous group. They are sure to bring a vibrant and unique, joyful dining experience for foodies, families, students, and young professionals alike. So there's info on Bubbly Hall in your digital packets. Moving on to the topic at hand today is our health. What our health means, both individually and collectively, as a community, nation, and world, has come into sharp focus over the last 2 years. Most everyone in our community has been touched by the pandemic in one way or another, causing us to consider and recognize the value and importance of our health. We've been provided an opportunity to examine and consider what factors make up our total health and well-being. And this is in fact the question that we'll discuss today. What factors or conditions comprise health? How do we achieve our optimum health, both individually and collectively? What is population and public health, and how does it relate to individual health and wellness? These are just some of the questions we'll discuss today with our panel of experts. Some of the information may be surprising to you, such as how much money we spend in the United States on healthcare and how that in fact does not translate into superior health outcomes. I won't give much more away. Instead, I would like to introduce our esteemed panel of experts today. First, Dr. Wapner is the director of the Center for Public Health Practice, the director of the Master of Public Health, the MPH program for experienced professionals, and a clinical assistant professor of public health in the Ohio State College of Public Health. As a practicing pediatrician with more than 7 years of public health and health policy experience, his primary interest lies in population health planning through integration of healthcare and public health, with a focus on social and physical environments and their impact on health status. Dr. Wapner is a board-certified pediatrician practicing in the nationwide Children's Hospital urgent care system. And prior to joining the College of Public Health, he served in multiple roles at the Ohio Department of Health, focusing primarily on chronic disease and population health. So welcome, Dr. Wapner.
Thank you so much, Angela, and thank everybody here for joining today. I'm going to go ahead and share my screen, and then please let me know how things are going. I will try to have the chat open as well so that I can keep a bit of an eye on whether questions come up. I do encourage questions, whether they're in the chat or you can simply unmute and ask. I don't mind being interrupted. I encourage it, and I do want to make sure that this presentation meets the needs that you have and the reason you came today. So I am going to pick up right where Angela left off, actually, and talk about this thing that we talk about a lot, or that you hear about a lot, which is we spend a lot of money on healthcare in the United States, but we don't seem to get the outcomes we would expect. And you know, I have a couple of charts that show some of this, and really just to visually clue everybody in how outside of reality the money we spend on healthcare is in the United States, and how far behind we are in many other countries for what we get for that money and that value proposition. So this is a chart of life expectancy at birth. So how long are people in each of these countries expected to live when they are born? And compared to the total healthcare expenditure per person for people in each country. So it's a little bit of old data, but this has really not changed lately. And in some cases might have even gotten worse with the pandemic and the increased hospitalizations and money that we've spent on healthcare in certain parts of the country. But what you can see here is the United States down in that big orange setting sun-like icon here, out toward the spending well above $8,000 per person. This is essentially per year on healthcare. And you notice that we're all the way down on the bottom of that line, which means that our life expectancy in the United States for all that money that we spend is dramatically lower than all of these other countries, which all spend less money and all have better life expectancy at birth. So this is just the beginning, right? This tells us that the United States is different. We are different in that we spend way more money than other countries, and we are different in that our life expectancy when you are born begins at a lower number than most of these other countries, all of these other countries, most other developed countries in the United States, or sorry, in the world. Let's look at infant mortality and healthcare costs. So this is shows similar thing, but specific toward the possibility of a newborn dying within the first year of life in the United States is higher than any other country. And yet again, you can see the money we spend on healthcare compared to our infant mortality rate is way out of proportion to our other countries that we're comparing here to. So really, to impress upon everybody just the sheer amount that the United States is an outlier compared to other countries, right? We do something different in the United States. On this chart, we spend way more and we get far fewer years of life out of that money. So let's talk a little bit about reasons that this might be. So I like this term social mess, right? When I think about what a public health issue is, a public health issue is anything that impacts the health of a population. A pandemic, opioid-related overdoses, tobacco use, overweight and obesity, chronic diseases. These are all the most common reasons to die in the United States today, the most common reasons we have a lower life expectancy now as a country than we did in previous years. What do these things have in common? They're all social messes, right? And this definition here is a social mess is a set of interrelated problems, resistant to analysis. So it's hard to really define all of the reasons why something is happening, and more importantly, to resolution. So it's really hard to identify what's at the core, and it's really hard to identify solutions. The social mess is characterized by uncertainty and risk, complexity, systems interacting with with other systems. So how does healthcare interact with public health, interact with the different social systems we have around transportation, around the economy, around employment? Competing points of view, which these days I don't know that I need to say more on how different we as a society approach problems. Values and the different people knowing different parts of the problem and possible solutions. And intra and inter-organizational politics, right? So a social mess is a very complicated, insidious problem with lots of different points of view, with lots of different agents, and lots of different factors that complicate and prevent a group finding a solution. And if we start thinking about public health problems as social messes, it will give us a perspective to look back at something like infant mortality, which has no single cause, which is rooted in factors that go well beyond just the mom's health, the moms-to-be health, and just the infant's health, and just the delivery method. But it speaks to the idea that there's more going on to what we as a society address with health problems. So let's talk about what these factors look like. This is a diagram. It's relatively simplified, but it still holds true. This was developed in 2014 by a group out of the University of Wisconsin that has been doing data analysis for every county in the United States that looks at all of these boxes and actually has outcomes and metrics data to rank every country in the United States on all of these boxes. What they have found out of their research, and has recently been corroborated by other research done at different levels, shows that when we have our health outcomes, desired health outcomes, right, which for most of us is a healthy, happy life, right? A life that's long. So we have at the top, our health outcomes of length of life and quality of life. Let's say those are the two outcomes of our population that are of most importance to most people, right? And let's say as decision makers, that's what we hope for the people that we consider our constituents. If you go down and start at the bottom of this graph or this diagram, you'll see that on the left, where you have the red box or orange box that says policies and programs, these policies and programs aren't just interventions from healthcare or public health. These are all of the policies and programs that we have put together over hundreds of years, right? That create different health factors, right? Our healthcare policies, developing into, even in the post-World War II era, when organized healthcare and health insurance began, that created health factors in terms of who has access to care and what quality of care they have. We have policies and programs that have dictated how people get employed, what the family and social support is. And I'm using these examples all from this right-hand column. All of these different factors that arise out of our policies and programs, and these are policies at the federal level, policies at the state level, policies in our own organizations, that create these factors, which if you go up from the orange box to the blue box, this box of health factors is made up of these subgroups, right? So let's look at this middle column. We have 4 subgroups that then this right column make up, right? So we start at the bottom. We have a physical environment. We have air and water quality. We have housing and transit, right? These are the things, when we look outside, these are the things that impact our health. We could add to water, we can add soil, right? Air, water, soil quality. The earth we live on, the air we breathe, the water we drink. If we need more examples of what this is like, let's turn to water quality in Flint, Michigan. Our most most widely known problem with water quality and lead poisoning. That's impacted thousands of kids and people's lives. But we can look at soil quality right in Columbus with some of our sites where our old factories have long since gone, but now have housing, low-income housing typically, in communities of color typically, that have decades and decades of waste buried in that soil. To air quality, right? To look at the 670 corridor. The 670 corridor built right by communities of color to add to pollution. Great example of the impact of air quality is in I believe it was the 1984 Olympics. I don't know, I might be dating myself, I can't remember. But when the Olympics were, I think it was 88, when the Olympics came to Atlanta and they shut down all of the intercity highway systems, and asthma rates and emergency visits due to asthma went down in communities of color because they didn't have that air pollution. We have a physical environment estimated to impact length of life and quality of life by about 10%, right? So you would expect that that impacting the physical environment might impact our health outcomes by about 10%. We move up to the next box and we get to social and economic factors: education, employment, income, family social support, community safety, estimated to impact these health outcomes of a population by about 40%. So just in these two health factors, 50% of the determination of how long and how and what quality our life will be is determined by things outside of what we typically consider our individual ability to change, right? So let's move up to clinical care, and we get that 20% number here. And that 20%, again, says clinical care is estimated to impact length of life and quality of life by about 20%. So I used to practice pediatrics full-time down in Athens, Ohio at Ohio University. And we cared for kids with, I think 20 different counties, all the way down to the border, all the way over into Western Ohio. We took care of a lot of kids, a lot of rural kids, a lot of generationally disparate health outcomes. At my best pediatrics practice, on my best day as a doctor, I am basically adding or contributing 20% of what I do with that patient in 15 minutes to their length of life and quality of life. As a doctor, I thought this was 80%. I thought it was all up to me, right? And it took working in public health for a decade to really see how little that contact I had with that person led to sustainable health outcomes or health improvement. We get to our final box of health behaviors, which is considered to be about 30%. Here's the caveat. Here's the thing I don't like about this chart, is that if you look at these health behaviors, you have sexual activity, alcohol and drug use, diet and exercise, and tobacco use. An inordinate amount of information and literature we have now will point to the fact that at least 50% of the causes or the risks that contribute to those health behaviors are due to those bottom two factors of social and economic and physical environment, right? Your ability to access healthy food via stores in your neighborhood or no stores in your neighborhood that serve healthy food and a healthy, affordable food. Your ability to live in a housing unit that does not allow tobacco use, or live in a community that has safe and well-maintained exercise facilities. All of that plays a very large role in the likelihood of you having one of these risky behaviors. So if we take this idea and we say that all of these things on the right-hand column, these light blue factors, these are the things that impact health. We have to ask, well, then if we as a public health community, and many in healthcare, but not most, understand that this actually is true. And again, this I can share a study with you for those who are interested. This was just, these numbers were essentially just held up with a rather large study that looked at different individual research studies and how they assessed impact of these different factors on length of life and quality of life. And these percentages still hold. And if this is true, then how does this country impact or seek to impact these health outcomes? So one of the tenets of public health right now is something called the population health approach. We can go back for 200 years and talk about the genesis of public health, beginning with infectious diseases and all of these other communicable ways that people died through poor sanitation, through uncontrolled epidemics where we didn't know really how to assess the community to look for these causes. We went through several stages of public health practice where we veered away from this idea that in order to keep people en masse from dying, we should be looking at things like sanitation, looking at things like our environment, our housing. We moved into this era, and it coincided with the development and the expansion of healthcare access, healthcare insurance, healthcare systems, that we approach problems in public health through an individual effort. How can I help this person change their risk factors and change their behaviors? Very similar to healthcare's approach when chronic diseases became the most common causes of death. We're now in this era of the population health approach, and I'll define population health a little bit later. But the key tenet of the population health approach is that we're no longer simply focusing on the individual. We're looking at these factors. We're looking at these reasons on the right-hand side of why people have different lengths of life from other people, why some people have a different quality of life than other people. And another way to think about these factors is this term, the social determinants of health. This is not by any stretch of the imagination a comprehensive list of social determinants, nor should you look at this chart and say, oh, so employment is its own factor over here, and hunger is its own factor over here, right? Because these are in different columns. The social determinants of health are these social, economic, environmental factors that we all live, learn, work, play, pray within, that impact our behavior, that impact our access, that impact our opportunity to be healthy, to make quote unquote healthy choices. This is the opportunity that communities have. And that's one way to think about social determinants, right? Think about these terms as being connected to each other, right? Hunger, housing, medical bills, health coverage, safety, housing, all of these things are interrelated and interdependent. And so when we talk about how do we impact health outcomes, we should be thinking back about that social mess definition, right? All of these factors are interrelated. All of these systems at the top, economics and education and food, healthcare, these are all different systems we live within that have their own policies, that have their own programs. They're all interrelated. And when you go through a scenario that we see every day in our community, we get the health outcomes in a way proportional to the amount of investment in these systems and how well these systems work together for health. Another way to look at this social determinant, this idea of social determinants, is at a population level. This is a picture of Cuyahoga County, Cleveland metropolitan area. This is data that's been done year after year after year and shows the same gap in life expectancy in a somewhat small area if you drive about 5 miles. So if you look at the yellow census tract on the right, zip code 44124, life expectancy in that community is 82 years. If you drive down 271 and exit right around that 480 interstate sign, you've just and buy a house or rent a house, your life expectancy is likely to drop to 75 years. If you then drive into core Cleveland in the inner ring suburbs, you're looking at a life expectancy as low as 70 years. This is all a commute within a 30-minute time span. Your life expectancy is based on where you live as much as it is on the hospital you might go to, if not exponentially more. So Angela mentioned this idea of funding, right? So the almost $10,000 per person in 2017 that the United States spends per person on healthcare per year shouldn't be surprising to you because we saw a number similar to that on the chart that I showed when we started the talk. And when you look at, for the same year, how much money the federal government puts into the Centers for Disease Control and Prevention, the CDC, per person per year, it's less than $22.50 per person, right? Now, there's a couple ways you can look at this. You can look at this as a stark comparison to the investment that the United States puts in to the federal public health institutions, which is the largest federal funder of public health programming, with just kind of a star and an exception there. But one of the most, it's basically the federal oversight of public health in the United States, spends about $22 per person versus what we spend on healthcare at about $10,000 per person. Now, I certainly am not going to say that it should be equal, because the whole point of public health is that you're spending money to keep vast numbers of people healthy, right? It is not exclusively cheaper to do it in every circumstance, but by and large, it's far cheaper to protect and prevent than it is to treat. But this discrepancy is still important because it reflects an ongoing, and this is within the state, absolutely within the state, as well as federally, it is absolutely the mind of most decision makers and most budget councils that public health doesn't have enough money to do the job. Healthcare does. We need to put more emphasis on healthcare, right? These are conscious decisions we've made time and time again at the state level in Ohio, is to say, well, but look at public health only gets $22 per person. They don't have the ability to do this. So we need to be putting more investment into healthcare. I would argue that that's exactly what this data is showing us not to do. Instead, maybe we need to balance this chart a little bit more. So this is another way to look at what we spend in the United States. This is a comparison for all of these countries. All of these, I believe, were represented on those initial charts that I showed you at the beginning. But this is a comparison of how each country funds healthcare and social care. Social care is a broad term. This could be childcare expenses. This could be employment expenses, housing expenses. This is essentially all of the other social spending in a country compared to healthcare. I hope you can notice the difference in the United States. We're the only country that spends more on healthcare than social care, almost by a 2-to-1 ratio. In every other country looked at, with the exception of Canada, which spends roughly equal, the country spends more on social care than healthcare. This isn't a causative relationship between why we have poor outcomes in the United States, but it's certainly, if we're talking about the social determinants of health as social factors that impact health, it is telling that the United States spends so much, and not just that the proportion is different, that we spend less than healthcare, but that we spend so much less on social care than any other country, right? So we obviously spend more on healthcare, but we spend so much less on social care too. So what do we do, right? How do we impact these factors? This is a relatively simple chart that shows that whereas policies and programs used to, or haven't always, and the programs used to in many ways target individuals and individual behavior, right? How do we get this person to quit smoking? That the way that we actually impact the social determinants is by looking at all of these different disparities, which I'm going to define in a second, and these factors, all of these factors, physical environment, social environment, individual factors, healthcare together. So this word now comes up as these disparities. And I actually want to go to this really quick, because this is how we're going to help define disparities in a way. So Ohio actually has its own population health definition. We created in 2017 as a group of people from healthcare, public health, community services, advocacy groups, to think through, in Ohio, what does it mean when we say population health? And so I want to focus on a few words within the population, because I think they really help define what it means when we talk about ideas of disparities. So we consider population health is the distribution of health outcomes across a geographically defined group, which result from the interaction between individual biology and behaviors, the social, familial, culture, economic, and physical environments that support or hinder well-being, and the effectiveness of the public health and healthcare systems. What I want to focus on are these yellow terms. Population health is the distribution of health outcomes across a geographically defined group, okay? Why? Back to our zip code map, why is there such a difference in life expectancy in those zip codes if they live so close to each other in the same city, in the same county, in the same state, in the same country? So we have to look at the differences in outcomes across two or more populations, right? That difference is called a disparity, right? It's a disparity in life expectancy, disparity in quality of life, in infant mortality. We see disparities in income and education, in all of these outcomes that we look at. All of these factors are available or impact communities differently. So that's how we consider what a disparity is when we think about health and the health of a population. And beyond that, it's the interaction between individuals, environments, and systems, right? So if we have this definition of population health, of what do we look at when we look at disparities? What are we looking for? What do we want to do about disparities? We have to look at this interaction. How do individuals who live in environments and are impacted by systems, what opportunities do they have to achieve the same outcomes as other populations? And why don't they? Why is this interaction impacting those outcomes negatively? So I'll leave you with this diagram out of California, which is kind of a linear way to think about where the population health approach, what the population health approach is trying to achieve. As a public health practitioner, as a healthcare practitioner, as someone who lives and works in community health, we spend most of our time on the right side of this diagram, and you can see that top arrow, that dark arrow with the word downstream on the right. We spend most of our time and money in the United States on disease and injury and mortality. That's where we put $10,000 a year per person in this country. What are we ignoring and neglecting in this spending when we're only putting $22 per person into public health? Is we're ignoring this block of factors under living conditions: the physical environment, the social environment, the service environment, economic and work environment. We're ignoring institutional inequalities that are created within and across corporations and businesses, government agencies, schools. I mean, schools is a great example of these institutional inequalities, where we have a home rule state with districts with their own freedom to make their own choices, and how people who live in communities with fewer opportunities and choices suffer because of that discrepancy, that inequality among institutions. And then all the way on the left, at this term called upstream, we have these social inequalities. We have parts of who we are as a society that in many ways, just because of these being present in a community, creates the inequality. And I know we're going to talk a little bit more about that and how that looks in the community itself. So we need, if you follow this down to the bottom, we need policy that looks at strategic partnerships and advocacy. We need to be able to link our communities to our organizations so that we can address and even identify areas of inequality in different communities. We have to look at our social inequality, our differences in opportunity based on race or ethnicity, on class, how all of these wrap together and create even more inequalities. When you look at Black women, Black LGBTQIA women, right? These barriers, these inequalities build on each other and they last generation to generation. So that's my talk. I know a lot of this will be brought to a local and personal level with the next two panelists, but I'm happy to take questions. Angela, if you want to do time for questions now or wait till after our panelists talk, that's fine. I'll do whatever you want.
Thank you so much, Dr. Wapner. That was perfect. It provided us, I think, that discussion to frame what's coming. If you do have questions, anyone, throw them in the chat and we will grab those. I don't see any currently. I think it would be a great time to introduce our next two panelists to kind of dig into the information that you just kind of set up for us. So thank you. That was very informative. I'll start with Dr. Chelsea Moreland. Dr. Moreland received her doctorate from The Ohio State University, where she was inducted into the Gold Humanism Honor Society and selected as a National Health Service Corps Scholar. She completed her residency training with Grant Family Practice of Ohio Health Grant Medical Center, where she continues to serve as adjunct faculty or community preceptor. She completed a concentration in women's health and obstetrics during her residency training and believes that full spectrum family-centered care is the key to addressing the maternal health crisis by bridging the gap. Dr. Moreland's interests and expertise are broad and purposeful, including medication-assisted treatment of addiction, adolescent health, and group prenatal care. Dr. Moreland founded the Life Cycle Direct Primary Care, which we are so happy to say is located directly across from the Heights Center. I walk across and see her in her office. So it's wonderful to have you as a neighbor here to us, Dr. Moreland, and thank you so much for being here.
Thank you so much for having me as a part of the panel today. I just wanted to further add, so the direct primary care practice really kind of was birthed out of my desire to help address these social determinants of health and how we are providing care equally to our community. I spent the last couple of years working in community health at a local FQHC, and I was able to see firsthand how kind of the system that we are used to getting healthcare in, what those downfalls are and how we continue to kind of create more barriers for people to have health equity. And so the direct primary care model is definitely newer to the area, even though it's been around for about 20 years in general. But I'm hoping that it will continue to help us strive towards health equity here in New Albany, but then also for our surrounding communities as well.
Thank you. And Dr. Moreland, if in all of our panel, feel free to, if you'd like, keep your mics off and just kind of jump in as you see fit. This is, the conversation will continue from here, so it's open for all of you. And I will now introduce Dr. Kiera Barnett. Dr. Barnett is a research scientist at the Center for Child Health, Equity, and Outcomes Research at Nationwide Children's Hospital. Her work focuses on the impact of structural racism and social determinants of health on racial and ethnic inequalities. Prior to joining NCH, Kiera completed a postdoctoral fellowship at the Kirwan Institute for the Study of Race and Ethnicity at The Ohio State University, where she collaborated with state, county, and city public health departments, as well as non-for-profit organizations to assess health outcomes and make policy recommendations to address disparities. She received her PhD in public health, specializing in health behavior and health promotion from The Ohio State University. She also holds an MPH from Ohio State and a BS in community health from the University of Illinois. Thank you so much, Dr. Barnett, for being with us today.
Thank you, Angela, and thank you for having me this afternoon.
I'm excited to start the discussion. I have 10 pages of questions, and I know we're only going to get to 3, so we will definitely reconvene this discussion in the future. But for today, I would love to start, Dr. Barnett, with you just to share a little bit about the work that you do every day at Nationwide.
Yeah, thank you. So here at Nationwide, I have my hands in a few different areas, but really focused on health equity and really understanding structural racism as well. And so here at Nationwide, we have what we call the Stand Against Racism, Stand for Health Equity Initiative. And so a part of my role here at the hospital is really to do some research around that. And so that research really encompasses kind of what are we doing as a hospital to really address some of these issues around racism. And really that connects back to this conversation we're having today around social determinants of health. When we think about, the inequities that Dr. Wapner talked about, where we see them happening in different communities, really what we have to understand is that's really rooted in a history of racism in our country that has, where we had historical racist policies that really set up the ways our communities are divided and separated. And we can talk a little bit more about that a little later in our conversation today. And I have a couple of slides that I can share as well related to that. So yeah, so I do a lot of work around, again, researching what we're doing as a hospital to address health equity. And then I also do a lot of work in the infant mortality space. So maternal and child health is really my focus area. And so as Dr. Wapner mentioned, we have these health inequities, not only, the US versus the rest of the world in terms of infant mortality, but here in Ohio, we have one of the worst infant mortality rates for Black babies in the country. And so the work that I do is really trying to understand kind of why that is, tackling some of these social determinants of health. Here we have programming that, we're involved in research projects that are looking at like, how do we house pregnant women, knowing that housing is one of the major social determinants of health. Right. And if you don't know where you're laying your head at night, you can't really start to process all these other things. What are you going to eat? Where are you going to work? Like you need that basics of having a roof over your head. And so really trying to provide that for pregnant women in the hopes that we'll see better birth outcomes than we have in some of the pilot studies that we've done so far here in Columbus. And so, yeah, just really focusing on understanding what are the experiences of pregnant moms here in Franklin County, and then how can we work with them to address those different social determinants of health to see better outcomes for themselves and their families.
Thank you. Dr. Moreland, I'd like for you, if you could, just to take a couple of minutes to explain a little bit about the direct primary care model, because I think a lot of people don't know what that is.
Absolutely. So direct primary care essentially takes out the middleman of insurance. And so we charge patients a flat monthly fee to have access to unlimited services in the office. And so particularly with life cycle DPC, because I am a full spectrum family physician, I'm able to provide care, as some people would say, cradle to grave. So all the way from the newborn stage to teenagers, to taking care of mom while she's pregnant, and then as well as helping my aging population to age well and make transitions. And so it's a beautiful model because it helps to save patients money. And so in the way that our current system works, a lot of people truly can't afford healthcare. And so, when we talk about how much we're spending per person on healthcare, the distribution of that expense is very different. And then also, how much someone spends out of their personal income is very different. When we first started the practice, one of the studies that we did as part of our market analysis was looking at how much each household spent on their healthcare throughout the year versus how much those households brought in every year. And it was actually pretty striking for me to discover that people who made the least actually spent the most of their income on healthcare. And so when we look at that, we're trying to find ways to help minimize that out of pocket, and having a direct primary care physician does that because we keep people out of the emergency room, out of urgent cares. We help people to not ever have to hit that out of pocket maximum that they're paying with their high deductible insurance plans. And so we help redistribute wealth as well, because if we're saving people money now, they can reallocate those resources to ensuring that their children have quality childcare, or go to a different school, or have transportation to school. And so we also help them to be able to have that safety for their family financially, because they can redistribute their wealth.
And I think it's really innovative and novel, the work that you do specifically related to adolescent medicine and health education. And I know, being here in New Albany, certainly adolescent health is of great concern to many families. Could you talk a little bit about what you're doing in your practice?
Yes. So another great part of direct primary care is that because we operate on that monthly fee basis, and we don't have to ascribe to kind of what insurance makes people do, we get to see fewer people per day and to distribute our time where it's needed. And so if we identify that, our adolescents locally need something, we're able to step away from the day-to-day services in the clinic to be able to provide those services to our community. So here locally, we've been doing a lot of vaccines for COVID-19. It's not something that benefits us financially at all, but because we have the flexibility in our time, we're able to do what's needed for the community. And so coming up this year, we're also going to start doing some fitness programming for our adolescents, where we do monthly sessions and they have an opportunity to talk about their healthcare concerns, but not necessarily the traditional bread and butter, like, hey, what's your weight today? But beyond that, the things that we know adolescents don't want to come to the doctor to talk about, and maybe don't talk to their families about, but to give them an opportunity to engage with the healthcare system or with a physician outside of an office, and to really help them to feel comfortable navigating that space and having difficult conversations with their primary care providers, so that hopefully we can impact their health early on, and make sure that they're interacting to the best of their ability with their healthcare system as they age.
That's wonderful. Thank you. I love to hear about that. It's exciting. Dr. Barnett, you said you had a few slides to share. Would this be a good time? Would you be willing to do that now?
Yeah, absolutely. Okay. Share my screen. So these slides really kind of point to kind of why we have to pay attention and why we should care about, when we talk about racism, like why should we care, and why does this history of racism in our country matter to this conversation around social determinants of health? And so really just wanting to acknowledge that these historical policies have shaped our present day communities and our neighborhoods. And so what you're seeing on this slide on the right is a map of redlining in the city of Columbus. And so many of you may have heard of redlining before, but essentially it was a practice done by the federal government. So this is to set a scene and tell a little story. So this is set in the 1930s through the 1950s. So at the time, the way in which we had mortgages in this country looked a lot different than what it did today. At that time, if you had a mortgage, you pretty much were paying monthly, but you were just really paying on the interest. You weren't really making payments on the principal balance. And so at the end of your mortgage term, you were expected to pay the full balance of the principal. And so if that sounds crazy to you, it sounds crazy to me. And so we had a lot of people who were defaulting on their mortgages at that time. So the federal government came in and said, okay, how can we help the banks not fail, right? Sounds familiar. And in that time, they said, okay, well, we're going to establish this federally backed mortgage, something that we still have today. But we need to figure out how are we going to assess who is eligible to get these mortgages. This is the 1930s, and we can have a discussion about what does race relations look like in 2022. But in 1930s, we know that it was that racism was very prevalent within our society in the 1930s. And so these decisions about what communities got access to these resources was really predicated or dependent on the racial makeup of the community. And so again, this redlining was this process of assessing neighborhood risk to determine the eligibility of that loan. Again, this established our modern day mortgage, and banks continue to use this practice in nearly every American city. So we only have red line maps for cities at that time, again, 1930 through the 1950s, that were of a certain population size. So Columbus fell within that. And so we have this map that shows what redline Columbus looks like. So what you see on the map, those red areas are where the Black population lived that were redlined. They were not eligible to receive this federally backed mortgage. If you received the A grading, you received 80% of your mortgage backed by the federal government. Therefore, you had to come up with a 20% down payment. Again, that is exactly when you buy a home today, what we're told that we need 20% down payment. It is based on this practice. And so we had, through this practice of redlining, we had communities that, again, were disinvested in. Individuals were not able to establish homes. That matters today in 2022 because we know in this country, the way in which we build wealth is through land ownership. This not only prevented a generation from owning land and creating wealth from themselves, but it also prevented those generations from passing that wealth down to future generations. And so in addition to redlining, we also had the construction of highways, and Dr. Wapner talked about that a little bit, about kind of what happened with the 670 belt and how it went through Black communities. And that's what you see in that image, those red lines. Those are the highways that were then built here in Franklin County and Columbus. And so when we were constructed our highways, so after we had, this creation of our suburbs, we needed to build highways to connect people back to downtown. And this is not specific to Columbus. We saw this all over the country. And really just pointing out that these highways were cutting through minority communities. So communities that had already been disinvested in because of this redlining practice that also not only prevented people from owning homes, but also impacted businesses being able to get loans to establish themselves in these communities as well. So we already have them being hit by one inequity, one injustice. And then we had the highway construction built on top of that cut these communities in half, cut the resources, the limited resources that they might have had, literally being cut and or taken away to make space for our highway construction. And so we see that happening. And if we look at what does this look like at a national level, these highways going through these different communities, at a national level, 47% of the US highways that have went through these HOC assessed areas, so the areas that had this assessment done through them, 47% of them went through degraded areas or those redlined areas, and compared to only 3% of highways actually disturbed what were our white and wealthy communities at the time. And if we look at Ohio, it's a little bit less, so only 35%. So in Ohio, most of them cut through our C-graded areas, but it's really important to know that those C-graded areas were, again, our low-income individuals. A lot of times at that time, it was low-income immigrant communities as well being impacted. And so these highways were impacting our minority and low-income communities more so than our white and wealthy communities. And so 70 plus years, Kira, why do we care about this in 2022? And it's really because it established the segregation that we still see today. So on a national level, if we look at all of those communities that got that A grading back in the 30s and the 50s, if we look at what does it look like in 2016, as of 2016, the A graded communities, 86% of them were still white. And 91% of those people living in those communities are still middle to upper income. And if we look at the degraded neighborhoods, those that were redlined, 64% of them as of 2016 were minority communities and 74% were low income. And so that historical policy matters because it created this present day segregation that we still see in our communities. And if we look at what does it look like specifically in Columbus, the numbers are about the same, where we see 91% of folks living in those A-graded communities are white, and 89% of them are that middle to upper income, compared to those D-graded neighborhoods, which is 47% minority, but 82% of them are still our low income. And so Dr. Wappner, I'm going to end with this, but Dr. Wappner talked about the fact that we have these communities that have, large gaps in life expectancy based on where you live. And so this is what life expectancy looks like in Franklin County. So where you see the darker blue areas are going to be where you see the higher life expectancies. And then the lighter green areas are where you see the lower life expectancy. And so you can see the gap between life expectancy, can be as great as 27 years just here in Franklin County. And what I really wanted to point out is that if we take a look at that red line map, and I know it's small at the top of the screen, but right here, kind of going down the center of the county, we see this upside down capital T shape where we see the yellow and the red communities. But if we look at what does life expectancy present day look like in Franklin County, we still see that same upside down T shape showing up. So again, just pointing to the fact that the things that we have done to our communities historically over 70 years ago are still impacting not only the resources that these communities have and who's living in them, but it's also having impacts on their health and their life expectancy. And so it's really important as we have these conversations around social determinants of health that we pay attention to that history, because if we don't pay attention to the history, we might start to look at the people who live in these communities and then blame the people for the conditions that they live in or for their health outcomes, not realizing the systemic ways in which we have created this system and the environment in which people live in every day.
Thank you, Dr. Barnett. If you could just package that last statement and we could blast it everywhere. It's such an important message. It's so important to communicate. Thank you. And I have a lot of questions, but I just want to open it up for the panel. If you have anything to jump in and you just want to comment on or say at this point. Okay. If not, I'll start with questions. To anyone, could we talk a little bit about the underserved and what traits or characteristics you would define as underserved, or how can someone be underserved? What does that mean?
So I think that is a big question. And I think there's so many definitions for how someone can be underserved, and it's relative. You know, I might be considered underserved in comparison to one of my neighbors, but I would not be considered underserved in comparison to some of my patients, for example. And so I think it is very much so relative. But one of the ways that I would point out that I think a lot of times we miss in healthcare is the type of providers that patients have access to, and how quickly they can access those providers. So the example that I'll give is in community health, the trend that we see is that the majority of the providers in those settings are nurse practitioners. And it's not to say that there's not a role for nurse practitioners, but we know in healthcare that the training is substantially different. I mean, some 10,000 hours different. And so if we think about that and we consider that we are giving the patients in our communities who have the highest level of need, who have been largely underserved and have not seen physicians or not seen a doctor in many, many years, who have very limited resources, very limited time, we're giving them a provider who has substantially less training and potentially needs a lot more support. So now we get into the problem of having so many referrals going into a system that is already so limited. And so how do we get them the resources they need now? When if we gave them access to more physicians, we probably wouldn't have that same upstream, you know, or I guess the same downstream effect of kind of clogging the system with referrals that were unnecessary, because they would have access to providers who could provide more care for them in-house. And even, you know, from a financial standpoint, a lot of that is financially driven, because we say we don't want to spend more to take care of this population. And so who can we pay the least amount of money? We can pay a new graduate nurse practitioner a lot less than we can pay a physician. And so what do? We stock our free clinics and our community health centers with non-physician providers. But again, we're talking about our, you know, our most needy population, a population of people who genuinely have substantial chronic illness burden, substantially minimized resources financially to be able to afford medications and referrals and things like that. And we're giving them providers who don't necessarily have the same experience to be able to care for them well, or optimally, should I say. And so I think that's one group of underserved that I think we tend to forget about.
Well, and I would say too, as I was digging through some research, just to be able to ask a couple of questions to Dr. Wagner about his presentation, it was interesting to me to find that half of all the healthcare spending actually goes towards 5% of the population. So it's not that high healthcare spenders aren't richer Americans buying up a lot of healthcare. It's not equal healthcare spenders, really. And this is a statistic from the National Institute of Healthcare Management, that half of the spending is going towards people with multiple chronic conditions like high blood pressure and diabetes. They take multiple trips to the hospital. They have more needs as far as medications go. I think that was a shock to me. I thought, wow, well, the story Dr. Wagner shared with us was really interesting, but that even provided more fine-tooth detail about how those dollars are being spent. And what do you do about it, I guess, is the question.
Were you going to jump in, Dr. Wagner?
Yes, sorry, Dr. Moreland. No, I was just going to say that, you know, in healthcare, it actually it's not a secret that most healthcare is used by a small number of people. And those people who use the most healthcare, as you mentioned, are more likely to have multiple chronic diseases. But they're also more likely to be in communities of color, more likely to be in low-income communities, more likely to have other social needs than just multiple chronic conditions and needing healthcare. And what we have been doing is putting more money into healthcare because the need is there. And I certainly am not going to suggest that the need is not. We spend $10,000 per person in healthcare a year in some ways because, and I think the pandemic has shown this, we have had poor outcomes for a long time. We have a lot of people in need. We have a lot of people in need that are so far more in need than other populations that the sheer number of people at high risk compared to those not at high risk is just, it's existed for so long in this country. For many things that Dr. Barnett has talked about, going back 200 years, 300 years, 400, I mean, it goes back to Europe. It goes back to disparities present in Europe. It goes back, it just, the interesting thing about public health or population health is that when you are burdened by these social factors, they accumulate over time, right? They accumulate physically over time, they accumulate socially over time. Dr. Barnett talked about the long-lasting impact of redlining, and that's Reconstruction, right? That's after slavery. But even in today, into our kids being born into these communities, these zip codes with low life expectancies, these are cumulative needs for social, right? It's cumulative needs for physical health too. And so we in a way, we can't not spend that money because we have people in need. We need to figure out how to untie that money from where the spending needs to be increased as well.
And what about class inequalities? What about socioeconomic? Can anyone jump on that?
Sorry, just to clarify, so do you mean like socioeconomic inequalities and like how the disparities in health outcomes look for different groups?
Right.
Yeah, I know a lot of times, I'm gonna jump back to race because it's important, right? Because I think a lot of times when we talk about the disparities that we see for different racial and ethnic groups, we forget that a lot of that is really entangled in this country, especially with socioeconomic status. So it does not mean that everybody who is, minority is low income. And we also know that for those with higher education and higher incomes who are minority, we still see health disparities in that population. But we do see a lot of coexisting, if you will, of those two identities, so being low income and being a person of minority. So we definitely see disparity happening across socioeconomic status, so across education, across income. Those with lower incomes are also some of the folks that we see the higher disparities in. So I think it really is important to pay attention to those communities, but also want to acknowledge that we do see these disparities in these higher income individuals as well. So I wanted to make sure that we don't leave those folks out as well.
And it seems to speak a little bit about prevention. I'm just kind of harking back to the presentation that Dr. Wapner, and the amount of money we spend on healthcare, and only what percent, 3% goes to prevention, right? Can't we get upstream? Can we start to think about this a little bit differently?
Yeah, I think we are, as a public health practice, at least, we are moving towards really trying to understand the prevention and understand these social determinants of health. Like, these conversations around social determinants of health are happening more and more. As Dr. Wapner alluded to, I think a lot of it is because of the pandemic has kind of opened people's eyes to the inequities that have been longstanding, but now we see them. So we heard a lot in the news about how, yeah, it's a lot of people who are low income, low wage workers who were having a lot of COVID infections throughout the pandemic, right? And it's not anything that those individuals are doing necessarily that put them more at risk. It's the nature of the work they do, their job, that puts them more at risk. It might be the fact that they don't have access to transportation, so they're relying on public transportation that exposes them to more individuals. And so I think that maybe that's like the silver spoon, that what can come from this pandemic is that it has shown a light of what the inequities that have been longstanding, and it has a lot of people's eyes on it that hadn't been paying attention to it before. Sorry, my mind went blank. I just forgot the original question, but yeah. So we social determinants of health. I think yeah, more folks are paying attention to it, and hopefully we can start to really address some of those determinants. And I think that we have to shift our thinking to thinking that healthcare can be the solution. As Dr. Wapner also alluded to, that is 20% of our health outcomes. And so if we focus all of our energy, all our finances on improving health outcomes for populations, we're only going to get 20% of the way. So at some point, we have to start shifting our minds, our resources to really addressing what's happening in a person's physical environment. What kind of what sort of access to stores or other resources are needed in communities outside of healthcare that we know are going to help people across a lifespan and improve their health.
Prevention was the word. We were talking about utilizing prevention and upstream. That's kind of where we were starting.
So I was going to jump in there when we talk about prevention because, you know, as Dr. Wapner mentioned, we have to kind of redistribute and untangle where those funds are going. And so we take this population of patients who have this chronic disease burden. Yes, they need access to care, but where do a lot of them get that care right now? And a lot of them get it in emergency rooms, in urgent care settings, the places that we know are extremely expensive, sometimes 3 to 5 times more than what you would spend on those items had they actually been seen in a primary care practice. But in our country, most people don't want to go into primary care. If you look at what a primary care provider makes compared to, you know, what a surgeon makes, of course, there's a big difference. Primary care is one of the lowest paid specialties in medicine. And so most people don't want to go into primary care, but primary care and prevention is where we know we need to be as a country spending most of our money.
And I would add to that, I think, again, we have to rethink what does prevention and primary care look like, because I'm not suggesting that doctors should be social workers, but it might be that physicians, you know, need to be assessing, you know, what are people's social determinants of health. So having, you know, some understanding of where people live so that as a physician, you don't say, well, hey, I see that you are at risk for diabetes. Let's talk about changing your diet without recognizing that a person lives in a food desert or a person doesn't have access to transportation to get to the nearest grocery store. And so I think to think about prevention, we have to also include these social determinants of health and like, how do we bring that as much as we can into the healthcare system?
And I think one of the ways that DPC helps to address that is that we have longer visits with our patients. So, you know, Dr. Wapner mentioned you have 15 minutes to do what you're supposed to do to impact this person's 20%. Well, that just doesn't work in a high need population. 15 minutes is barely enough time for someone to get in a room, let alone enough time for me to do the counseling and better yet the listening that I need to do as a physician to know what truly are your barriers that are getting in the way of me being able to help you achieve your health goals. And so even just having more time to understand our patients so they can buy into the plans and so that we can help connect them with resources. Because even though, yes, we go to medical school and we study diseases, we also bring to the table our own life experiences and connections. And so we are very well connected individuals as physicians and capable of helping to steer our patients to more resources. You know, how hard is it to hand a patient a list of food pantries as we're saying, hey, these are the things that we need you to start working on. I know it's difficult. Here are some resources to help do that. Better yet, can I go grocery shopping with you if need be? But if I work in a system that ties me to that office and that says you need to see more patients per day, I can't possibly do that no matter how much I want to.
Well, and I think it brings me to, we always like to talk locally as well, right? So I think we have to be honest about, it's a spectrum. We here in New Albany, we are not a high need population. However, so it's important to understand where those high need populations are, why they're there, the history, and how to manage and help in those high need areas. But I think that it's worth saying there are some needs even in this community, even in New Albany, with our population, differences in socioeconomic status, differences in minority needs. And I know when we spoke in advance, Dr. Moreland, you said, and it was eye-opening to me, you know, patients want to be seen by a physician that looks like them, where they can connect to. And I thought, you're right, you know, what a privilege it's been for me to not have to really think deeply about that, but how true that is. And I just wonder if you could share just a little bit about your personal experience of healthcare here in New Albany.
Absolutely. You know, as I was opening the practice, it came to my attention that here locally, we didn't have any pediatric provider, primary care provider that looked like our minority population. And so with Ohio Health coming, with OSU coming, now we're starting to change what that looks like. But myself and one of my colleagues who just graduated in the past 3 or 4 years were the first primary care providers in the community that were African-American. And, you know, it's 2022. It just seems like, man, that took a long time. But in that, you know, I think a lot of people to your point, kind of overlooked that and say, well, it doesn't really matter. The people who live here are wealthy, they have money, but that does not change their experience when they go to a physician, and the best example of that, I would say, is when we look at the maternal health crisis. An African-American female who is pregnant, whether she is rich or poor, whether she has a PhD or no degree, has the same risk of not leaving that hospital, of dying in childbirth. And so, and that in part comes down to bias in healthcare and not having providers or people in the healthcare system that look like them, who will stand up for them, or who can, who kind of understand their background and where they're coming from, and who can help advocate for them. And so here locally, I think that our community, as we've diversified in our community in terms of who lives here, we haven't diversified in terms of who's working here, who's actually providing services here. And so I have definitely seen an influx of people who are just like, man, I'm happy that I can finally come to the doctor's office and not necessarily have to explain why I feel certain things or explain why I think certain things. And I don't have to have in the back of my mind that someone's going to judge something about me that they just don't understand. And not because they don't want to, but genuinely because they don't come from the same background.
And I think, and that's where you talk about cultural competence and cultural humility. I think, and you have a beautiful saying on your website that Life Cycle DPC is committed to maintaining a safe, culturally competent, and judgment-free experience for all patients, regardless of race, socioeconomic status, gender, ethnicity, politics, religion, or vices. At no time will advocates of hate or exclusion be tolerated in our practice for any reason. And I think it's beautiful just affirming that in your work. So it's an honor to have you in our community.
Thank you. And I would say the past couple of years, I was just going to say the past couple of years when I worked in community health, I was exposed to far more diversity in my practice than what I'd even been exposed to in medical school and prior to medical school. And one of the things that stood out to me is that it didn't necessarily matter if I didn't share the same religion or if I wasn't from the same exact, community or country. But what mattered to my patients was that I was willing to acknowledge our differences and to respect them and find value in them, and be willing to manage their healthcare around their personal barriers and to respect that. And so that was really important for us to put on our website front and center that is what our policy is. And we will, in medical culture in general, I think we used to have it so that, the physician was the end all be all. This is what I say, do what I say. Not that I am your partner, not that I'm working with you. And I just want to help you connect the dots to how to get to a better health, to your personal best health, with all of the things in mind that are important to you.
And just to highlight what Dr. Moreland is talking about, I dropped a link to a Washington Post article that came out last year, showing that mortality rates for Black babies was drastically decreased when they were seen by Black physicians after their birth. So there is some research behind it. So not just people's personal experience about kind of how they can have improved health when they have physicians that look like them, but also some research that shows that we see better health outcomes for the patients as well.
Thank you for sharing that. We'll put that in the in our virtual shared file. You will all receive a virtual shared file that'll have the different presentations and some literature in it as well. So that'll be forthcoming. I think it's also important, we talked a little bit about adolescents in the community. We want to be and we're working really hard to bring in the perspectives of our adolescents and our students in the community. I wonder, Dr. Moreland, if you could share a little bit about what kids are experiencing and adolescents in our community, particularly minority students.
So I would say here locally, one of the things that I have personally seen is that there's I would say that there's just a disparity in representation. So if we've only had, if the pediatrics in our community only looks one way, I think we've kind of displaced a lot of our students into making them feel like they don't have representation in healthcare here locally. So how do you have the conversation about food? How do you have the conversation about, your body composition? Because we know these are the things that are coming up for our adolescents right now, right? It's a time in their life where they are very much so focused on the physical and forming relationships. And, even when you think about our LGBTQ youth, who are they interacting with in healthcare? Do they feel welcomed when they're going into our healthcare facilities here in our community? And so I think those are the places where our teens have been kind of missing that connection. And even in terms of substance use, it's a hot topic amongst teens, but do they have somewhere safe to go where they are having these conversations and have advocates? And so being a full spectrum practice, that's something that we are going to be hopefully kind of changing for New Albany, because we do provide full spectrum services, and we want our teams to be able to come in and have access to that. And I also love group care. And so my experience with group care really mostly has been prenatal care. So being able to help use the power of the collective voices of people to help them to grow and how they're looking at their pregnancies. But so the same can be applied to how we help treat adolescents. And so being able to form groups even with adolescents is something that I'm hoping that we can do in the future, so that they can have that opportunity to grow and share from one another. Because again, we think about disparities, every household here is different. And so maybe some of our teens have a perspective that another teen in the same community just hasn't yet developed, or has a resource that another teen doesn't yet have. And so I'm hopeful that we'll be able to help address those issues by bringing our teams together through some initiatives that we'll be starting.
Thank you. I just want to kind of go back to the once over the world vision and think, back to, like, as we talked with Dr. Wapner earlier, the US healthcare system being the most expensive in the world. However, we're living relatively unhealthier and shorter lives. What can we be doing about this as we kind of wrap up here in the next 10 minutes? What is the single most important thing maybe we can be doing here locally in our communities and our families? Dr. Wapner, you gave us the problem. You have to give us the solution.
So remember, solutions to social messes, or another way to think about it is wicked problems, are multifactorial, right? So I'm a white male of very good means. So, but what I tell people and what I try to do is I mean, like, you could take it all the way. Like, I encourage people to vote for those who don't have as much as they do, and advocate for those who don't have as much as they do. And one of the things that I learned, and I know there's been some resources put in there in the chat, but Heather McGee's book, I'm blanking on the name, but Heather McGee's book, and we can put it in the chat, really talks about the benefit to society when people who are disadvantaged are brought up to the level of others. And there is so much to be gained by removing disparities and reaching equity for everybody. There is so much cost to society in time, talent, treasure that we waste because we have disparities. And it's a burden on everybody. Thank you to some of us. And I think just for people to understand that, when people outside of your community struggle, your community is struggling. You might not see it, but it's there. And it's there in every part of our lives. And so I think when we make decisions for those who don't have what we have, we can start to at least tear some of that stuff down. In who we advocate for, and how we vote, in how we spend our money, in there's just a lot of ways to be an active, even if you're not an advocate out in public, to advocate for communities who don't have, and advocate against policies that don't consider people who don't have.
Anyone else want to jump in on that? I think, well, I'm not going to speak. I'll let you go, and then I'll ask the next question.
Yeah, just want to also to illustrate. So, like, while we are a country that spends the most in healthcare costs, we're also a country that has one of the highest wealth inequalities in the world as well. And so that's really important to think about, again, going back to the social determinants of health. And, when we have those wealth inequalities, that means that we have a large amount of people in this country without access to some of the bare basics that we need to be healthy and live a whole and complete life. So that's really important to point out. And I think, adding to what Dr. Wapner just said, I think the way in which we can become better advocates is making sure that we also are listening to the voices of the people that we're trying to advocate for. So not making assumptions, even, myself as a researcher and health disparities, a lot of the stuff that I do is qualitative, and I'm really trying to get into the community, and for the people that I'm trying to serve, really getting into the community and hearing from them what they need, and not making assumptions about the things that I read or the stories that I hear. I really want to hear directly from the mouths of the people. So I think that's something that to consider, like as we're being advocates, just making sure that we're advocating for these things that people say that they need most.
Anything to add, Dr. Moreland?
I saw someone's hand went up, like they had a question, so I didn't want to miss them. Okay. So the only thing I guess that I was going to add to that is to Dr. Wapner's point, if we're making decisions, to make them with the people who often, go unheard and who have less than us in mind. And I know I shared this with you all as something that stood out to me this past year or two as we've been dealing with the pandemic. But, here locally, it was a very big deal, with New Albany deciding where we're going to do virtual learning, where we're going to do hybrid learning, where we're going to have our children completely in person. And even aside from the actual, people getting sick aspects, so even outside of that, one of the things that stood out to me is that we had neighbors in Columbus who had no option of where to send their children during this time. We had neighbors who had no internet. We had neighbors who had no safe childcare during this time, who had no other choice but to go to work and to leave their children at home. And so who came to the call? You had some churches and some small businesses that came to the call and watched children and gave them internet access to do their virtual learning. But here we were as a community fighting when we had the opportunity to even free up, space in our school to say, let another school come in and do and learn right here in the safety of our buildings, because our children have access to more resources, because a lot of our children have parents who work from home. We can form groups, where someone's watching everyone's child for the day or something, but we have access to something that our neighboring community didn't. And we didn't care at all about that. We spent more time arguing about missing events and other things that just in the grand scheme of things were so much smaller than what our neighbors were dealing with. And so I just say that to echo what Dr. Wapner, stated, make these decisions with other people in mind, because there are people who have a lot less than we do. And I think as you start to do that and to think outside of yourself, I think we will start to see a lot of these things change.
Agreed. I will say, just knowing a family that visits our food pantry, they were driving for Amazon, right? And driving for, Grubhub, and they were carrying their kids with them certain days, even when we weren't in school, because they had nothing else to do. And they were young children that you couldn't leave at home. So they drove around with mom and dad 8-10 hours a day. I mean, that's happening even here in our community. So that's real. And that's really important to remember. We're not all so privileged to sit at home in our, warm houses and with internet and so forth. Dr. Robbins?
Yeah, Angela, I'd like to make a brief comment about resources related to the social determinants of health, because we have something here that most communities in America don't have, and that's the Children's Advocacy Project, known as CAP for Kids. And there are handout cards that are 8 by 3 inches. The people from Children's, I hope, are familiar with. And we started that about 11 years ago, and it's for just about any resource you could possibly find in Central Ohio, inside the city and surrounding the city, related to adverse childhood experiences and the social determinants of health. And anybody can get through them online, whether it's at home or through a library or through schools. And in 2020, there were 170,000 visits in Central Ohio to this resource. So there are ways of helping. There's also ways of hooking it all up on your electronic health record for healthcare providers that take seconds. So I've done it, and So it doesn't take a lot of time to do this. And you can get people to very specific resources very, very quickly. We are blessed to have this. And it's through children's CP, what? Yeah, yes, through children's pediatricians or CPP, which is based in Nationwide Children's Hospital, children's practicing pediatricians. And so it's very simple to get these. The cards are available. There's thousands of them that we give out every year. We actually give them to practically every child in city schools. So I just mentioned that. So there are strategies that we can do that can be very helpful to our community.
Thank you, Dr. Robbins. I posted it in the chat for those of you. In fact, our director for the food pantry is on this call, so she'll have access to that, and we'll share that with our resource library at the food pantry. Dr. Robbins is one of our local pediatricians for a number of years, so we greatly appreciate that information, Dr. Robbins.
Thank you.
And I'll add, I know here at Nationwide Children's, we actually do collect information on our patients. I think it's not happening at all of our clinics, but I know that we're switching up how we're collecting it. And I think there's plans to expand it out to all our clinics, where we currently, we're getting ready to start a new system in February, but currently every year, children who are seen at particular clinics are asked 4 questions to measure some social determinants of health. So it's asking, if they have, if they are housing unstable, if they have issues with utilities, if they need access to food, and I'm blanking on what the 4th one is, but we ask those questions of families once a year. And then if they answer yes to any of those questions, we then ask if they have an immediate need, like, do you have somewhere to stay today? Do you need food today? And depending on how they answer the question, they might get an information sheet of like where to get these resources. But if they have an immediate need, we direct them or connect them directly to a social worker who can help them. And so that's something we're doing here at Nationwide Children's. I know different hospitals also have different mechanisms of how we can collect the social determinants of health kind of information on families and then connect them to needed resources. Thank you for sharing.
Thank you. Anyone else have any final thoughts? Otherwise, I'll do a quick wrap up. Okay. Thank you so much, all of you, the 3 panelists, for being here today, not just for your time today, but my goodness, the work you do every day changes lives. From the bottom of my heart, thank you. And I just want to share with you that this presentation will be provided in a link on a YouTube channel, so you'll be able to share it out. Please share it. Let's just get the dialogue going with our community leaders and our friends and our family members. So when you receive that, feel free to share it on any type of social media platform you would like. Also, you will be provided a digital packet with some resources and info in it. 2 upcoming Lunch and Learn topics to talk about. In February, we will be talking with the Family Center for Safety and Healing on relational safety, tech safety, and teen dating violence. And then in March, I'm super starstruck, to be honest. I'm so excited and nervous that we have moderating for us our very own Dr. Wando Oliawala. She, if you don't know her, is a New Albany resident, as well as the Chief Health Equity Officer and Senior Vice President at Humana and OPS. She was in Essence magazine as one of 8 Black women to watch in corporate America. So she is a local star, and I'm so excited to have her moderate our panel in March. So those 2 are upcoming. Please join us. We hope to be in person at that point. If there are other topics you'd like to hear about, just shoot them to me and we will dig into them. And thank you all so much for your participation today and the work you all 3 do every day. Thank you.
Thank you for everything.
Moderating behind the scenes.
Thank you.
Thank you.